Good afternoon, doctors. We are the Group 6, and our report is about papillary thyroid carcinoma. And the consultant for our group would be Dr. Melanie Grace Y. Cruz. And here are our members: PGI Aguirre Ira Joanna and Turks. For our history, general data, JP, a 56-year-old female, married, Filipino, Roman Catholic, lives in Caloocan City and is a retired teacher. The chief complaint is anterior neck mass. For our history of present illness, 5 years prior to admission, the patient noticed a pea-sized mass, approximately 1 centimeter across on the left side of her neck, characterized as painless, hard mass which moves on swallowing. There were no associated symptoms, no consultations made. During the interim, the mass was slowly increasing in size without any associated symptoms such as fever, cold, sore throat, body malaise, change in voice quality, difficulty swallowing, and difficulty breathing. And there were no consultations was done. 1 year prior to admission, there was persistent enlargement of her neck mass, which already started to become bothersome for the patient, hindering her to function fully with regards to her daily activities. There were no associated symptoms, and then no consultations done. So 5 months prior to admission, there was an increase in size approximately 4 centimeters in diameter, characterized as painless, hard, nodular with irregular borders and moves when swallowing. There is hoarseness, difficulty swallowing, weight loss, specifically losing 2 kilograms in the past 2 months. No medications were taken and no consultations were made. So 1 day prior to admission, the mass grew in size to approximately 6 centimeters in diameter, painless, hard, nodular with irregular borders and moves on swallowing. There is persistence of the hoarseness, difficulty swallowing, and unintentional weight loss. The worsening symptoms caused alarm to the patient, prompting the patient to seek consultation in Fatima University Medical Center, outpatient department.
For the past medical history, the patient has unrecalled childhood and adult vaccination, no history of illnesses such as hypertension, diabetes mellitus, stroke, and asthma, no medications taken, no known allergy to foods and medications. She had a history of radiation therapy in the past, but unable to recall the specific indication. No previous hospitalization or surgeries, no blood and other blood product transfusion was done. For the family history, the patient's parents are both alive and well. Her father, 76 years old, diagnosed with a goiter 20 years ago. No regular checkup was done. No other heredofamilial diseases reported. For the personal and social history, the patient was born and raised in Caloocan. She is a college graduate and retired teacher. She is non-smoker, an occasional drinker, and denies illicit use of illegal drugs. She eats 3 times a day, consists mostly of rice and red meat. Her sleep pattern from 10 p.m. to 6 a.m. She lives in a bungalow house with her parents. The house is well ventilated with 3 bedrooms and 1 bathroom. The water supply comes from Maynilad, and distilled water is used for drinking. The garbage is collected every Wednesday, and no history of contraceptive use in the past.
For the OB gynecologic history, so our OB score is Gravida 2, Para 2, 2002. For the first pregnancy, it was on the year 1992, term NSD, nor, delivered normal cesarean, normal spontaneous delivery, attended by an OB, and delivered in Sampaloc Hospital, a baby girl, alive. And then for the second baby, 1997, AUG was term, delivered NSD, attended by an OB. And then the place of the delivery was in a lying in at Valenzuela. Baby boy with and birth weight of 2,900 grams and is alive. For the menstrual history, so the our patient started her menarche at 14 years old, and then it lasted for 3 to 5 days, and 3 pads per day with dysmenorrheal symptoms, and the interval would be 28 to 30 days, uh, 2 to 3 days, and 2 pads per day without dysmenorrheal symptoms. For the gynecologic history, so Koitark was at 21 years old with only one sexual partner, no STIs, and menopause would be 48 years old.
For the review of systems, all are unremarkable.
Physical examination. The patient general survey. The patient conscious, coherent, oriented to time, place, person, and calm. Able to speak in sentences, appear, good posture, ambulatory with steady gait. Right hand side, blood pressure 120 over 80 millimeter left arm, pulse 80 beat per minute, respiratory rate 20 cycles per minute, and temperature 36.5 Celsius. Skin warm to touch, dry, mobile with good skin turgor, no skin lesion, and eyelid not swollen, lash not matted, pink palpable conjunctiva with visible vasculature, no lesion and no discharge, white sclera, transparent cornea, no opacity and no ulcer. Paranasal sinus, no tenderness, bilaterally positive, resonant, heard on percussion, and transillumination, frontal sinus positive, dim red growth seen over frontal area bilaterally, maxillary sinus positive, dim red growth seen on heard palate bilaterally. Otoscopy, no target tenderness, both ear, non-hyperemic external auditory canal, intact tympanic membrane, and no oral discharge, both ears. Anterior rhinoscopy, nasal septum in midline, no intranasal mass, no tenderness, and no bleeding, moist nasal mucosa, no discharge, and nasal turbinate, pink in color. Posterior rhinoscopy, no post-nasal drip, and no mass seen. Oral cavity and pharynx, moist buccal mucosa, no lesion, no pigmentation, no pooling of saliva, tongue midline upon protrusion and retraction. The gingiva is pinkish, no bleeding, uvula midline and tonsil not enlarged. Indirect laryngoscopy, adequate glottic opening, vocal cord midline on phonation, no vocal cord mass, non-hyperemic epiglottis and arytenoid, and no pooling of saliva. Face and neck, take here in midline. The patient have left anterior neck 6 to 7 centimeter, hard, nodular, non-tender mass with irregular borders, move with deglutition, no facial asymmetry, and no palpable cervical lymph node. Physical examination, chest and lung, symmetrical chest expansion, no retraction, clear and equal breath sound. Cardiovascular, carotid pulse strong, regular and equal without blood and on both right and left carotid arteries. Apical beat is palpable at fifth left intercostal space, mid-clavicular line, her rhythm regular, no blood and no murmur. Abdomen flat, asymmetrical, soft and non-tender. Musculoskeletal, no limited length of motion, no muscle and joint tenderness. Extremity, ghostly normal extremity, no cyanosis, no edema and no lesion. Neurologic examination. The patient has conscious, coherent, cooperative, oriented-time, place and person, can do finger-to-nose test, rapid alternating movement, and heel-to-chin test with ease. Negative lumbar side, cranial nerves intact. Muscle normal tonic have a muscle strength index of 5 or extremity. Joint reflex intact, symmetrical, normal reflective, negative Babinski and meningeal sign, and no sensory deficit.
And for the salient features of our patient, 56 years old, female, 6 by 7 centimeter hard, nodular non-tender mass with irregular borders, located on the left anterior neck, which moves with deglutition. Past medical history, history of radiation therapy. Family history, father diagnosed with goiter. The diagnosis, papillary thyroid carcinoma. Tender mass.
For the anatomy of the thyroid gland, the thyroid is composed of two lateral lobes connected by an isthmus, which rest at the level of the second to the fourth tracheal cartilages. The thyroid gland is a butterfly-shaped, vascular, red-brown endocrine gland situated in the midline of the anterior neck, extending from the level of the fifth cervical vertebra down to the first thoracic vertebra. The gland weighs between 15 to 25 grams and measures approximately 4 centimeters in height, 1.5 centimeter in width, and 2 centimeter in depth. Next slide, please. So the arterial supply to the thyroid is from the superior thyroid artery, a branch of the external carotid artery, and the inferior thyroid artery, a branch of the thyrocervical trunk. The thyroid veins include the superior, middle, and inferior thyroid veins. The superior thyroid vein derives as a branch of the internal jugular vein and travels with the superior thyroid artery in the superior pole vascular pedicle. The middle thyroid vein travels without arterial complement and drains into the internal jugular vein. The inferior thyroid vein also travels without arterial complement, extending from the inferior pole to the internal jugular or brachiocephalic vein. Now, the thyroid gland usually grows posteriorly and inferiorly since it is limited from upward extension by the sternothyroid muscle. The middle layer of the deep cervical fascia condenses posteriorly, forming the posterior suspensory ligament or your berry ligament that connects the lobes of the thyroid to the cricoid cartilage and the first two tracheal rings. Next slide, please. So, the thyroid gland is innervated by your parasympathetic nerve fibers arising from the superior laryngeal nerve and the recurrent laryngeal nerve. The sympathetic nerve fibers supplied to the thyroid gland comes from the superior, middle, and inferior cervical sympathetic ganglia. Lymph drains mainly laterally into the deep cervical lymph nodes, while a few lymph vessels descend to the paratracheal nodes. Next slide, please. So, the secretory function of your follicular cells, which are responsible for the production of hormones in the thyroid gland, are controlled by the thyroid stimulating hormone, or the TSH, which released from the adenohypophysis. The thyroid gland also contains your parafollicular cells. Now, these cells appear on the periphery of the follicular epithelium as single cells or as cells clusters between the follicles. The parafollicular cells are not part of the thyroid follicles and are not in contact with the colloid. So the parafollicular cells synthesize and secrete the hormone called calcitonin into the capillaries. The main function of the calcitonin is to lower the blood calcium levels in the body.
So I will now discuss the physiology for the thyroid hormone synthesis, storage, and release. Next slide, please. The thyroid hormone synthesis, storage, and secretion is composed of multiple and highly coordinated steps, which includes iodine uptake or trapping, oxidation, organification or iodination, coupling, storage, and release. For the thyroid hormone synthesis, it starts when iodide have entered into the cytoplasm, and it will cross the apical membrane into the lumen again, aided by the carrier protein, which is what we call the pendrine, which is a sodium iodide importer. The next step will be the iodides undergoing oxidation, being converted into iodine, and this reaction is catalyzed by enzyme peroxidase. The third step is the organification or iodination, wherein the tyrosine component of the thyroglobulin molecules will bind to the iodine, producing two thyroid hormones, which what we call the iodotyrosine. We have two iodotyrosine, the MIT or the monoiodotyrosine, and the DIT, which is the diiodotyrosine. The next step is what we call the coupling. In coupling, the two other thyroid hormones are produced, meaning one MIT plus one DIT will now be converted into T3 and two DIT will now be converted into T4. Next slide, please. A large pool of thyroid hormone is stored in the follicular lumen, and as a colloid containing iodinated thyroglobulin, stored colloid subsequently undergoes pinocytosis and fuses with lysosomes, where T3 and T4 are cleaved from thyroglobulin and will be released into the circulation, whereas the DIT, the residual DIT, and the MIT are recovered back into the cytoplasmic pool. For the regulation of thyroid hormone synthesis, it is regulated by the hypothalamic pituitary thyroid axis, which is one of the classic negative feedback loops between the pituitary and its target organs. The thyroid stimulating hormone or the thyrotropin is secreted by the pituitary gland in pulsatile fashion with a diurnal rhythm and stimulates multiple steps in thyroid hormone synthesis and release. In turn, this TSH release, secretion, and bioactivity are stimulated by hypothalamic thyrotropin releasing hormone. The thyroid hormone exerts negative feedback directly at the pituitary to inhibit the TSH and indirectly at the hypothalamus to inhibit the TRH. And the TSH is the major regulator of the thyroid hormone synthesis and release. I will now discuss the physiology of the papillary thyroid carcinoma. The papillary thyroid carcinoma represents the most common form of thyroid cancers. In our patient, it is presented with anterior neck mass, which is the chief complaint of the patient, pea-sized mass of less than 1 centimeter, painless, hard, which moves on swallowing, followed by hoarseness and difficulty in swallowing 5 months prior to consultation, are associated with genetic alterations. Therefore, the DNA mutations can cause thyroid cells to become cancer, wherein the proto-oncogenes RET and BRAF are the genes that codes and promote cell growth and proliferation, which will turn into oncogenes. And these oncogenes, the protein which forces the cells to always divide and causes the thyroid cell to become a tumor. And then this DNA mutations turns off the tumor suppressor genes, which allows the thyroid cells to divide uncontrollably, leading to producing nodules that are non-functional. In histology, the papillary thyroid carcinoma have papillae, which are the finger-like prolongation of follicle cells that tends to grow slowly and invade the lymph nodes in the neck. And under the microscope, we have the orphan Ani nucleus, which is the nuclei that have papillary carcinoma cells and contains a very few proteins and small amount of DNA.
So for the pathology part, next slide please. Yeah, so for the pathology, so whenever there is a mutation in our RET gene, which is actually present on chromosome number 10 and encodes for tyrosine kinase, that is when we get to see this pathology. So for our papillary thyroid carcinoma, there are two defining genetic abnormalities that can be seen. Either they can be a translocation that results in gene fusion of RET or NTRK, or secondly, we can see a point mutation in our BRAF. Next slide, please. So whenever there's a reciprocal translocation between our chromosome number 10 and 17, it results in the formation of RET-PTC gene. Or whenever there's a translocation in our NTRK1, it results in the overactivity of our tyrosine kinase pathway, which actually results in the unregulated cell growth and differentiation. Secondly, whenever there is a point mutation in our BRAF gene, it is most commonly seen when valine is replaced by glutamate at codon 600. It leads to gain in mutation of this gene, leading to disruption of MAP kinase signaling pathway, resulting in an unregulated cell growth and differentiation. So there are actually a few more points I would like to add on to our pathology segment. That is, whenever we see a RET gene fusing with our PTC, it is more likely associated with sporadic form of papillary carcinoma. And whenever we get to see a BRAF gene mutation in our patient, it is associated with poor prognosis because in these cases, what we see is decreased expression of our thyroid markers and increased risk of extrathyroidal extension. So that's it from our part.
So for the differential diagnosis, first would be non-toxic goiter. Rule in, the patient is a 56 years old female with non-tender and painless mass with a family history of goiter. Rule out because there's an unintentional weight loss and mostly non-toxic goiter don't have any specified symptoms like unintentional weight loss, but we must check for subclinical hyperthyroidism. There is also no history of mentioned iodine deficiency. The patient had a history of radiation therapy, but it is not specific. There is no history of autoimmune disease. Another one would be parathyroid carcinoma because the patient is a 56-year-old. There's an anterior neck mass, hoarseness, and difficulty swallowing. Ruled out because mostly in parathyroid carcinoma, patients already have severe symptoms like kidney stones, painful bones, abdominal groans, psychic moans, fatigue overtones, which is a classic pentad of hyperparathyroidism. And usually, parathyroid carcinoma is uncommon because there's only less than 1% of cases. And there's no... Next, please. Another one would be thyroid nodule, a 56-year-old female with a painless anterior neck mass, family history of goiter, having a weight loss, and rule out because the mass is increasing in size and usually thyroid nodules don't exceed a measurement of more than 5 centimeters.
So the next is Hashimoto's thyroiditis. We consider this because of the patient's age, which is 56 years old, female, and the duration of the neck mass, which is around 5 years. Plus there's a painless neck mass with irregular borders. but she has a hoarse voice and difficulty swallowing. So we ruled it out because of there's no history of hypothyroidism and there's no specific history of external radiation. The next is follicular thyroid carcinoma. So we consider this because of the patient's age, her gender, there's a painless neck mass, and her weight loss. We ruled this out because of the slow growth of the neck mass. And differentiating papillary and follicular thyroid cancer is difficult, and it requires histology through fine needle aspiration. So for the papillary thyroid carcinoma, you will see a large clear nuclei with powdery chromatin. This is called the orphan eye, ani eye. And for the follicular, there should be a presence of capsular and or vascular invasion.
For the diagnostics po. So here's our algorithm for the evaluation of thyroid nodules detected by palpation or imaging. So good history and thorough physical examination is needed, and uh, thyroid stimulating hormone measurement should be performed. So next one. So for thyroid function tests to measure patients' TSH, FT4, and FT3 to determine the overall function or state of the thyroid, if it's euthyroid, hypothyroid, or hyperthyroid. No necessary preparation needed for this exam except for patients who take thyroid medications because it can alter the results. So first, thyroid stimulating hormone is the most important test for thyroid function. The TSH levels change dynamically in response of alterations of T4 and T3. Two limitations of TSH. First, it assumes the hypothalamic pituitary function is intact and normal. And second, it assumes that the patient is stable. So for thyroxine measurements are often used along with TSH and can be important in interpreting TSH results, specifically FT4 or free thyroxine. FT4 is a biologically active fraction of thyroxine in circulating blood. And then triiodothyronine. Triiodothyronine is much less bound to serum protein than thyroxine. The serum level of T3 measurement is helpful in confirming the diagnosis of hyperthyroidism, especially in patients with no or minimally elevated T4 or ambiguous clinical manifestation. 20% of T3 is thyroidal in origin and 80% is produced enzymatically in non-thyroidal tissues by monodeiodination of T4. Important for diagnosis of hyperthyroidism but not in hypothyroidism. So for our patient's result, there's an increased TSH level, but normal FT4 and FT3. So we will proceed po with diagnostic ultrasound po. So for the diagnostic thyroid ultrasound, evidence-based guidelines recommend thyroid ultrasonography for all patients suspected of having thyroid nodules by either physical examination or another imaging study. Ultrasound is useful for nodule size and for the aspiration of nodules or cystic lesions. So for the ultrasound result of the patient, so as you can see, there's macro and micro calcifications on the left lobe of the thyroid of the patient. So there's a 6 by 7 centimeter hyperechoic solid nodules with the infiltrative borders and micro and macro calcifications, indicative patterns that suggest that nodules may be malignant. So next for our algorithm is fine needle aspiration biopsy. So FNAB has become the single most important test in the evaluation of thyroid masses and can be performed with or without ultrasound guidance. Ultrasound guidance is recommended for nodules that are difficult to palpate, for cystic or solid cystic nodules that recur after the initial aspiration, and for multinodular goiters. So for the result po, uh, there's cells with characteristic empty nuclear or large clear nuclei with powdery chromatin, sometimes called orphan iony nuclei, and with nuclear grooves with prominent nuclei. So for TNM staging, because T3, because the patient's tumor is 6 by 7 in diameter but limited to thyroid, and 0 because no enlarged lymph nodes, and 0 because there's no distant metastasis. So because the age of the patient is more than 45 years old, according to the TNM classification, it is stage 3, T3, N0, N0.
For the general management of papillary thyroid carcinoma, we have four main components for management. First is adequate surgical removal of the disease. Second is adjunctive RAI ablation in selected cases. Third is TSH suppression. And fourth is surveillance. Unilateral thyroid lobectomy and its mastectomy is adequate unless there are evidences of angioinvasion, multifocality, or positive margins. Usually recommended is total or near total thyroidectomy. The presence of micrometastasis will require radioactive iodine ablation therapy to effectively detect and treat residual thyroid tissue. It is approximately given 4 to 6 weeks after surgical thyroid removal. We also give a hormonal replacement, which is levothyroxine.
Management, measure level of thyroglobulin, assessment risk of tumor by ultrasound and CT scan, find needle biopsy and microscopic for checks pathological of carcinoma. Recommended to total thyroidectomy because size of tumor is 6 times 7 cm in diameter. Suggest to do capsular neck dissection. Encountering the recurrent laryngeal nerve. Routine identifying the external branch of the superior laryngeal nerve. Plan for management. Treat with levothyroxine 150 microgram after total thyroidectomy. This to begin 5 days after surgery. Radioactive iodine treatment can be given as early as 4 to 5 weeks following total thyroidectomy, but can be delayed for months or even years following surgery. Measure level of thyroglobulin after surgery for check risk of recurrence of papillary thyroid carcinoma. Measure level of calcium and magnesium because total thyroidectomy that dissection parathyroid also. This is the plans for management. Are include low, intermediate, and high. If suppress thyroglobulin, low every 6 months, intermediate every 6 months or so, and high every 6 months or so. Stimulate thyroglobulin, low risk, no require, intermediate every 1 to 2 years, and high every 1 to 2 years or so. And next ultrasound, low recurrent every 1 years, intermediate 1 years, and high 1 year also. And diagnostic RAI, low recurrent, no require, intermediate and high every 1 years. And CT scan or MRI, no routine consideration. This is a reference of our presentation. Thank you.